Good afternoon, everyone. My name is Kristen Baugnon. I'm a head and neck radiologist from Emory University, and I'm thrilled to represent the American Society of Head and Neck Radiology and welcome you all to another outstanding Talking Head and Neck educational webinar. I just want to first acknowledge that we have people joining us from all over the world today, and we're very excited about that. Before I do get started, however, I'd like to plug our upcoming ASHNR annual meeting, which will run virtually from September 9th through 13th. It'll feature 5 days full of excellent educational content from many wonderful speakers across the country, including the great ones that we're going to hear from today. I love this society so much, and now that it's virtual, it can be even easier for more people to benefit from the outstanding lectures. So you can go to this website or use your phone camera for the QR code here to register. And for a little bit of housekeeping for today's webinar, if you have any questions for the presenters during the talk, please don't hesitate to ask using the Q&A panel, which will be monitored by Dr. Char Branstetter, my fellow moderator, and will lead to discussion with the speakers following the presentation. Also, feel free to use the chat box to discuss amongst yourselves and connect with your fellow attendees. However, remember that you can minimize the chat box in your Zoom control panel at any time if you do find it distracting. The activity does offer one approved AMA category CME credit, and you can claim this credit by going to the ASNR Education Connection website after the webinar, which is listed here. And then remember, I have to introduce the learning objectives and disclosures. So upon completion of this activity, participants should have strategies to understand the updated AJCC and UICC 8th edition staging categories for oral cancer, and understand the patterns of spread of squamous cell carcinoma and how imaging can help planning of surgical resection for oral cancer, as well as review normal anatomy and subsites of oropharyngeal squamous cell carcinoma and discuss spread patterns, and give you some information that should be included in our reports. And our speakers and moderators have nothing to disclose. And one final shameless plug for our upcoming Talking Head and Neck webinars. On August 27th, we have the famous Dr. Karen Salzman speaking about fascia and spaces, as well as the always entertaining Dr. Phil Chapman, who'll be going over some cases. That'll be an excellent session moderated by Drs. Karen Mahler and Dan Williams. Then again, the virtual ASHNR 2020 meeting from September 9th to 13th, as well as the first ever joint European and American Societies of Head and Neck Radiology webinar on September 22nd. So stay tuned for information regarding that. Okay, without further ado, I want to introduce our speakers for today. So first, and obviously they really need no introduction, but first we'll have Dr. Hilda Stambuk, who will discuss the oral cavity. Dr. Stambuk is an attending neuroradiologist and professor of radiology at Memorial Sloan Kettering Cancer Center and Weill Medical College of Cornell University in New York. Dr. Stambuk has been on the staff of Memorial Sloan Kettering Cancer Center since 2000, where she is currently the director of head and neck radiology. Dr. Stambuk is an experienced and avid educator who has written numerous peer-reviewed articles and book chapters on imaging of head and neck tumors, including the best-selling surgical textbook, Jatin Shah's Atlas of Head and Neck Surgery and Oncology, and the web-based DX. But in addition to this, she's just an all-around lovely person and a wonderful speaker, so I'm very excited to hear her speak. As well as, after Dr. Stambuk, we're going to have Dr. Suresh Mukherji review the oropharynx. Dr. Mukherji is a clinical professor at Marian University and the director of head and neck radiology at ProScan Imaging. He's also the regional medical director in Vision Physician Services and the medical director for Economic Alliance of Michigan. Dr. Mukherji is a past president of the American Society of Head and Neck Radiology, was a member of the 8th edition AJCC Head and Neck Expert Panel, and is an internationally renowned head and neck radiologist and lecturer. Also, as a personal side note, I will forever be grateful to him for allowing me the opportunity to speak at my very first ASHNR meeting in San Diego many years ago, which was an unforgettable experience. So now I'm going to stop sharing, and we're going to go ahead and get going with the lectures.
So I wanted to thank ASHNR for putting together these webinars. It's a privilege to be a part of this wonderful effort. I also wanted to thank Kristen Baugnon for inviting me today to speak on oral cavity carcinoma. In this talk, I'm going to go over a brief update on AJCC 8th edition in regards to T category. We're going to discuss squamous cell carcinoma primarily because it's the #1 tumor in the oral cavity, and I'm going to show you various spread patterns. Also, I'm going to show you imaging findings that help in planning surgical resection. And I want you guys to know that the oral cavity tumors are treated primarily by surgery, not by radiation or chemo-RT. So the 8th edition AJCC UICC staging system was first published in October 2016, but put into effect in January 1 of 2018. And the major change that we all need to know about is that the clinical and pathologic depth of invasion are now used to increase the T category. Why is depth of invasion of the primary tumor important? Well, we've seen clinically over the years that the thinner the lesion, the less likely the patient's going to have nodal metastases, and they're going to have a higher cancer-specific survival. When you look at these slides, you can see that the deeper the lesions are, the more likely they're going to have nodal metastases, and you can see how the cancer-specific survival plummets. So depth of invasion is super important. How was it measured on the old edition? Well, they would just use the maximum surface diameter for the T category, but now we do the maximum surface diameter plus the depth of invasion, and that's what makes up the T category in AJCC 8. So previously, tumors that were less than 2 centimeters in size were T1 category, 2 to 4 centimeters in size were T2 category, and greater than 4 centimeters in size were T3 category. But you can see we've now added depth of invasion to enhance the T category. So here's a pictorial depiction of what I'm talking about. It makes it easier to understand. So tumors that are less than 2 centimeters in size are T1 category. However, they have to be less than 5 millimeters in depth under AJCC 8 to still be T1. The minute this small tumor is greater than 5 millimeters in depth, it's upstaged to a T2 category. Now, if a tumor is 2 to 4 centimeters in size, it should be T2 category. However, the depth of invasion has to be less than 10 millimeters. If it's greater than 10 millimeters in depth, this tumor is going to be upstaged to T3. Okay. If the tumor is greater than 4 centimeters in size, but the depth of invasion is less than 10 millimeters, it's T3 category. However, if it's deeper than 10 millimeters, it's going to be upstaged to T4A category. Or if it has bone or skin invasion and are invading other structures, it also makes it T4A. So depth of invasion is kind of difficult to estimate. I guess the easiest, but still not easy site to evaluate on clinical examination is the tongue, where you can do physical examination and bimanual palpation and figure out the size of the lesion. Where it's even harder is for other subsites like the mandible, the gums, the gingiva, the retromolar, trigone, hard palate. And that's where we help by using imaging, CT or MRI in the US. Europe uses ultrasound a lot, and we're starting to use it more. And it's something to keep an eye on because I think it's very promising. So it's important to know what we can see and where we can help and what we can't see. So the superficial disease, the mucosal disease, is far better seen by the clinician. We really can't see it well at all in imaging, so let the clinicians figure that part out. Where we help is the things that they can't see. The submucosal and the deep extension. Is there vascular involvement? Is there bone invasion? Is there perineural spread of disease? A lot of folks want to know which is better, CT versus MRI, and we all know the answer to that. They're both great. They're not mutually exclusive. They have their pros and cons, and I'll show you an example where we can use them to complement each other. That being said, I really love CT for the oral cavity because you can scan from the skull base to the carina in 60 seconds or less, so it's a fast scan and you don't get artifact. CT is also great for looking for extranodal extension. It's far earlier in detecting this finding than MRI or clinical examination. And oral cavity tumors tend to invade the cortex before the medullary space, and CT is far better in evaluating the bone cortex than MRI. So that's the advantage of CT. Of course, there's disadvantages for CT, but the one that irks us the most, as you all know, is the beam hardening artifact from dental work. We can do angling around the mandible, around the teeth like we always do. We can also apply the metallic artifact reduction algorithm, but sometimes we just can't see the underlying tumor. MRI has its advantages, and I'm going to stop right here and tell you that I really prefer MRI for hard palate tumors, and I'll show you examples why. Overall, MRI is great for tumor muscle interface, perineural spread, and it's also really wonderful when a tumor goes from like hard palate into the sinuses to differentiate tumor from inflammatory mucosal change. MRI obviously has its limitations. Remember that MRI takes about 30 to 40 minutes to get a scan for a subsite. So if a patient has a large bulky tumor and they have pooling of secretions, they're going to be coughing and choking, and you'll get this really bad motion degraded non-diagnostic scan. So it's important, not only do you pick the right modality for the tumor, but you got to pick the right modality for the patient with the tumor, what they can handle. Okay, it's important to understand how squamous cell behaves so that we know how to evaluate it. So remember that squamous cell does not respect the fascial planes. It blows through the tissues. It invades bone more commonly than most tumors. It can have perineural spread of disease. And of all the cancers in the head and neck, it has the highest propensity for nodal metastases. I'm going to start looking at some of the subsites of the oral cavity. We're going to start with the oral tongue and the floor of mouth. We're going to start looking at cases. So when you have early superficial disease, all we can really do is give the size of the tumor. I give the tumor in 3 dimensions so that they know what the depth of invasion is. They know the way that the tumor is growing and let them decide. So once tumors go beyond being superficial, I want to see, are they in the extrinsic tongue muscles? Are they in the genioglossus, the styloglossus, and most importantly, the hyoglossus? Here's a coronal CT. Here is a axial CT. And you can see here is the mandible. This is a tumor in the oral cavity. It's large. You can see that it's definitely in both of the genioglossus muscles. These are extrinsic tongue muscles. On this axial view, you can see a gorgeous curvilinear muscle called the hyoglossus muscle. It's a very important landmark for where the neurovascular bundle is for the tongue. It looks great here. The muscle looks great. I don't see it here. So this hyoglossus muscle is infiltrated and the neurovascular bundle is gone. So we talked about tumor, how big it is. Does it go to the extrinsic muscles? Next, I want to know, does it cross midline? There's many reasons to document why it crosses, whether or not it crosses midline. And one of the most important reasons is these tumors, not only for surgical resection planning, but when they cross midline are more likely to have bilateral neck nodal disease. We also want to look at the tumor's proximity to the neurovascular bundle. And why is that important? Well, when you resect the tumor, you don't just get a gross resection. You want to make a wide oncologic margin with normal tissue intervening, so you make sure you get all the tumor and you have a nice rim of normal tissue that you got all of it out. So this cut here would depict a wide oncologic margin, and you can see it makes you take the neurovascular bundle. However, the remnant tongue will be left with the right neurovascular bundle, so you'll have innervation to the remnant tongue as well as perfusion. So here's a patient with a right lateral oral tongue tumor. Here's a patient with a large tumor that crosses midline, is in the genioglossus muscles. You can see that the hyoglossus is spared, but it's not spared on the right. However, in order to get a wide oncologic margin, you're going to have to take the left hyoglossus muscle, which means you're going to have to take bilateral neurovascular bundles. This patient would therefore have to get a total glossectomy if they went to surgery. The surgeon needs to know this in advance, because sometimes they just opt out for chemo-RT because having a total glossectomy is pretty devastating. We also want to look for tumor relative to bone. Is it in the mandible? Is it close to the mandible? Is it in the hyoid bone? Is it close to it? Also, surgeons come to me a lot when they're palpating tumors in the floor of mouth and they're feeling something in the submandibular space. They want to know, is the tumor going through and through the mylohyoid muscle and into the submandibular space? Because if that's the case, if that's what they're feeling on exam, this patient needs an en bloc resection. However, if the tumor is just blocking the submandibular gland duct and causing the gland to swell and be obstructed, that's not tumor they're palpating, it's just a swollen gland. Or is it just nodal metastasis? It seems it's very easy for us to differentiate, but it's really hard sometimes on clinical examination. So here's a patient with a large tumor in the oral tongue, goes in the floor of mouth, through the mylohyoid into the submandibular space. This patient needs an en bloc resection. Here's a patient that had tumor in the anterior floor of mouth. It's not going in the posterior floor of mouth. It's just anterior. It's causing obstruction, dilatation, and a fluid-filled left submandibular gland duct. And therefore, you can see that the left submandibular gland is very swollen as opposed to the normal-looking right gland. So what they're palpating here in the submandibular space is a swollen gland, not nodal metastasis, and not through and through extension. So oral cavity, floor of mouth tumors, you want to give the size of the tumor in all three planes. You want to tell them if it crosses midline. The surgeon is palpating something in the submandibular space. So what are they palpating? We can see that the duct is obstructed. So this is a swollen gland, not lymph node. And finally, what's its relationship to the bone? This tumor is actually invading the symphysis, and we need to include that in our report. Retromolar trigone and buccal mucosa is another subsite which has a special spread pattern. Tumors in this site are pretty awful. Where the retromolar trigone is the space behind the last molar tooth on the mandible, and it's the most posterior aspect of the buccal mucosa. The tumors here can easily invade the bone and jump on the nerves, but there's also this raphe, the pterygomandibular raphe, this fibrous structure that attaches along the medial surface or the lingual surface of the mandible along the mylohyoid line, crosses over the retromolar trigone, as you see here, goes from mandible, and it goes up and attaches to the medial pterygoid plate. This is the pterygomandibular raphe. You can see the connection from mandible to maxilla. But the pterygomandibular raphe, as you see here next to the retromolar trigone, is also an insertion point for the buccinator muscle and also the superior constrictor muscle, which makes tumor travel along here onto the palatine tonsil. So we need to look for this. So here's a patient with a retromolar trigone tumor. You can see what normal looks like. You can see some fatty tissue and some mucosa. This is too much soft tissue. It's going far too medial. So we know already it's on the pterygomandibular raphe. So look on the left side where you see normal buccinator muscle, nice and thin and well defined. It's too thick here and it's infiltrated. So tumor is gone onto the pterygomandibular raphe, onto the buccinator muscle. Same patient on coronal plane, you can see the nice mucosa of the retromolar trigone going on to the buccal mucosa. You've got some fat here. Here it's too much soft tissue. This is the tumor. And you look again on the buccinator muscle more anteriorly. It's nice and thin and well defined. On the right hand side, it's infiltrated and fluffy and thick. This is tumor in the buccinator muscle. Here's another very important case. This patient has a retromolar trigone tumor that was easily seen clinically, but what I'm going to show you from now on was only submucosal location and could not be seen on clinical examination. This tumor from the retromolar trigone got on the pterygomandibular raphe along the superior constrictor muscle and made its way onto the palatine tonsil. This is a pattern we really need to recognize because I don't want people to think this is an oropharynx primary. It's not. It's a retromolar trigone oral cavity tumor that needs surgical resection. Okay, so this tumor, it's made its way cephalad onto the palatine tonsil. We look inferiorly, and remember that the pterygomandibular raphe goes inferiorly and attaches along the lingual surface of the mandible, along the mylohyoid line, so you can see this tumor tracking medial to the mandible and actually taking a part of the lingual surface of the mandible out. It goes further, and you can see that there's diffuse enlargement and enhancement of the right mylohyoid muscle. You can see it's much bigger and more enhancing than the left-hand side. To confirm that, you can see on coronal imaging normal mylohyoid muscle. This muscle is too big and enhancing, so the tumor on the pterygomandibular raphe attached to the mylohyoid line, the tumor rolled over onto the mylohyoid muscle. All of this was submucosal in location, and we needed to tell the surgeon so that they could do a nice wide oncologic resection and help the patient get the best operation. So we've talked about soft tissues of the oral cavity, the tumors, but how do we take care of the mandible? Well, if you have tumor in the oral cavity and it's adjacent to the cortex but not in it, you still want to get a wide oncologic margin, a nice resection of normal tissue. So with this scenario, you can take a rim or a margin of the bone, leave enough bone behind so when the patients chew in the future, they don't fracture, because remember that the mandible is strongest along its inferior border. So you can take a nice marginal mandibulectomy. Here's an example of tumor on the lower mandibular alveolus, wasn't in the bone, so we got a nice marginal mandibulectomy, and the patient went on to successful healing. Here's another depiction when the tumor actually goes in the cortex or the medullary space. You have to take out a segment of the bone. That is called a segmental mandibulectomy, and obviously this patient is going to need reconstruction. So here's a patient with an oral tongue floor of mouth tumor. It's abutting the cortex of the mandible, but it's not infiltrating it. So this patient, same patient, is a great patient for a marginal mandibulectomy, and they'll have enough bone stock left for good function. Here's another depiction where the tumor goes into the medullary space of the bone. And here's a real-life presentation of a lower alveolus tumor that actually invaded the bone. So you know you're going to have to cut out a segment of the bone and do reconstruction. So I told you already that oral cavity tumors primarily go into the cortex first, but they can go into the medullary space. Medullary involvement is better seen on MRI, where cortical involvement is better seen on CT. So let's look at pre-contrast T1, because that's the best way to evaluate the mandible, because you're going to have fatty marrow that's white and the black cortex. So as we make our way along the mandible, you can see a patient has gingivobuccal sulcus tumor, and you can see this gray infiltration from canine back from tumor involving the medullary space of the mandible. Post-contrast imaging shows you the gingivobuccal sulcus tumor invading the bone, but if you didn't look at the pre-contrast imaging, I think you would miss that the tumor goes all the way to the canine, so please don't forget to look at your pre-contrast T1 weighted images. So how does this look on CT? You can see that the cortex is out, but you really can't appreciate the medullary disease. So the question is, why don't we just do MRI for the oral cavity? And I'm going to show you why. Here's a pre-contrast T1 weighted image. You can see this is a low-grade tumor at the left sublingual gland adenoid cystic carcinoma, not invading the cortex. And you can see the fatty marrow is nice and white. It goes beyond the tumor, and then it becomes gray after the tumor. So what's going on? This is when you want to pull in another modality, CT. You see sclerotic bone in the medullary space, not sclerotic on the opposite side. This patient's had prior dental extractions. So any patient that's had any inflammation or infection in the oral cavity in the past is going to have sclerotic changes in the bone. That's going to look low T1 marrow signal. It's going to enhance, and generally is going to be high T2 signal. And since a lot of people have this sclerosis, you can see how MRI would cause over-calling tumor involvement of the mandible with oral cavity tumors. Okay, so I've shown you how to evaluate the soft tissue tumor, how to evaluate the mandible for resection, but now we can actually help the surgeons plan for bony resection and reconstruction by CAD/CAM planning, which is computer-assisted design and computer-assisted modeling. So what do? I work with a head and neck surgeon, and we plan where the anterior osteotomy cut will be. We plan the posterior osteotomy cut, and we make a second in case we need to do a bigger incision. We take all the data from this discussion. We talk to, on the WebEx, we'll talk with the dental surgeons, with the plastic surgeons, the head and neck surgeons, and then the modeling company, and they'll make this wonderful, after we decide where we want to cut. And with all this pre-planning, they'll make this wonderful plastic cutting device that we use in the OR. And you can see that this cutting device shows you exactly where to do your bone saw cuts. And it helps you get a very precise segmental mandibulectomy as well as a marginal mandibulectomy. And while this is happening in the OR, the plastic surgeons also did CAD/CAM planning on the fibula. So they have their own cutting device. They know where to cut on the mandible. They would know where the best vascular flow is. And they use this model to reconstruct the mandible while it's still pedicled to the patient's leg. And the dentists go ahead and put, at this point, the implants. Then, so all this is done, the head and neck surgeon working at the head, the plastic surgeon, and the dentist working on the lower extremity. They bring the fibular free flap up, and they secure it with a custom fixation plate. And you can see the dental implants are already in place. Okay, so you bring your flap over, and in 3 to 4 weeks before the patient goes to RT, if they need it, they've already got their prosthesis in, and you can see they're going on to fuller function faster, but also by this pre-planning, the OR time is far less and is actually more precise and better for the patient. Hard palate is another subsite, and it has special challenges in its tumor spread pattern. So you can definitely have squamous cell carcinoma along the hard palate mucosa. But this is also a place where we commonly see minor salivary gland tumors that arise from minor salivary gland rests that are submucosal in location, so sometimes they could be hard to see. These tumors, particularly adenoid cystic carcinoma, have a propensity for perineural spread of disease. Remember I told you squamous cell has a high frequency of nodal metastases? Well, mucoepidermoid carcinoma likes to go to the lymph nodes. Interestingly enough, adenoid cystic kind of doesn't like the lymph nodes at all, but likes to skip straight on and have lung metastases. So when a patient has a submucosal mass in the hard palate, our job is to tell the surgeon if it's in the bone or not, and did it go in the nasal cavity, maxillary sinus, or did it go in the soft palate? Bone involvement is super important to know in advance, because if the surgeon has to go in and cut the bone, you want to have a plan for obturator already made, or how they're going to primary close it, because if you leave a hole there, when they eat food, it's going to go from the oral cavity and up their nose. So we need to know in advance what's going on. Okay, hard palate, nice fatty white marrow. Here's the expanded adenoid cystic tumor. You can see it's already in the nasal cavity. It's already gone laterally into the maxillary sinus. Same patient, look at the fatty marrow in the hard palate. I can see fatty marrow much better on MRI than appreciating it on CT. This tumor went into the hard palate bone, nasal cavity, and maxillary sinus. You can see how T2 shows you the gray tumor, very distinct from the nasal cavity turbinates. And if there was fluid in the maxillary sinus, it would easily distinguish tumor from inflammatory mucosal change far better than CT. This tumor is enhancing, but the reason why I'm showing you it on axial imaging is to show you how close it is to the pterygopalatine fossa and the greater and lesser palatine canal. So now you know it's adenoid cystic, who loves nerves. So the next thing we're going to talk about, perineural spread of disease. Okay, so V2 goes into the pterygopalatine fossa, terminating in the greater and lesser palatine nerves. So, you know, if you have a hard palate tumor, it can jump on these nerves, go up the pterygopalatine fossa, along V2 foramen rotundum, and so on. So here's a patient that had adenoid cystic carcinoma of the hard palate. It actually grew into the maxillary sinus, and it actually broke through the back wall into the pterygopalatine fossa. You can see it's infiltrated. It looks enhancing and very different from the fat-suppressed, non-enhancing left pterygopalatine fossa. That's normal on the left. So I expect to see tumor along V2 because this is adenoid cystic carcinoma. So sure enough, the right V2 is too big. It's too large and enhancing compared to left V2. And if you're not sure, look at your coronal imaging. V2 is too big and enhancing, as opposed to the opposite side, as is the vidian nerve that also has perineural spread of disease, too large and enhancing relative to left V2. This tumor skipped the neck, no nodal metastases, but it definitely went to the pulmonary. You have pulmonary nodules. These are cannonball metastases, very classic and common in adenoid cystic carcinoma. Okay. Here's a patient that had resection of a right floor of mouth, adenoid cystic carcinoma, and here's flap reconstruction. But you can see there's a tubular nodular structure here left behind. And if you follow it up the medial border of the mandible, you can see this tubular structure. What happened here? Well, this is actually the lingual nerve. The tumor from the floor of mouth got on the lingual nerve, and it's making its way up V3. So you can see it's made its way up V3, and it's making its way towards foramen ovale. So you can easily see perineural spread of disease on CT, but I'm not going to kid you, we all know MRI is more easily showing perineural spread of disease in this case. Okay, so in this lecture, I'm showing you that what our job is. It's not the superficial disease, but it's the deep disease. We can tell the surgeons where the submucosal and deep extension of the tumor is. We can tell them where the vascular involvement is, bone invasion, and perineural spread of disease. We can also identify subtle findings that will help in staging, planning, therapy, and improving outcomes. So I really want to thank you for your time and attention.
Hello and good afternoon. For the next 25 minutes or so, I'm going to be giving a talk on oropharynx with a specific emphasis on oropharyngeal carcinoma. And I want to thank the talking heads and necks of the ASHNR for allowing me to give this presentation. First, we'll talk about the anatomy, and anatomy is so important when it comes to the head and neck. I consider the oropharynx as a almost a rectangular box, and the anterior border of the oropharynx is formed by the circumvallate papilla and the anterior tonsillar pillar. The posterior margin is formed by the posterior pharyngeal wall. The superior margin is formed by the soft palate. The inferior margin is formed by the vallecula, and the lateral margins are formed by the anterior tonsillar pillar, the tonsillar fossa, and the posterior tonsillar pillar. And again, we're going to go over in great detail all of this anatomy. The four primary subsites of the oropharynx are the tongue base, the soft palate, the tonsil, and the posterior pharyngeal wall. And again, we'll go over all this in great detail. So we'll first start off with the tongue base. So the tongue base is located posterior to the circumvallate papilla. So everything anterior to the circumvallate papilla is in the oral tongue. Everything posterior to the circumvallate papilla is in the tongue base. The middle image identifies a schematic illustration of a tongue-based carcinomas with the potential spread patterns. And on the right, we can see a right-sided tongue-based carcinoma that's encasing the lingual artery. So on the bottom left-hand side, we can see a tongue-based carcinoma that's lateralized, and on the right-hand side, we can see a tongue-based carcinoma that's crossing midline. So when we talk about information that needs to be included on your report, and we'll emphasize this later, is first of all to measure the size, because when we are looking at staging, we have to measure the size of the tumor. And then also, one of the key things, and easy to identify typically, is whether or not it crosses the midline. When we look at the tonsil, there are actually three components for the tonsil. The most common site of tonsillar carcinomas is arising from the palatine or the fascial tonsil. So this arrow forms at the palatine or the fascial tonsil. Either of those terms is fine. And below it is a schematic illustration of a palatine tonsillar carcinoma. Now on the left-hand side, the white arrow points to this little fold of tissue, which is referred to as the anterior tonsillar pillar. The anterior tonsillar pillar is formed by the paladoglossus muscle. And one key indicator that a tumor is involving the anterior tonsillar pillar is that the tumor has an anterior spread pattern. So when we go back to the top left schematic illustration, this muscle that's just lateral to this is the superior constrictor muscle. The muscle anterior lateral to it is the buccinator muscle, and where they interdigitate here is in the pterygomandibular raphe. So you can see the anterior tonsillar pillar is along the anterior border of the tonsil. When tumors extend deeply, they can grow anteriorly along the superior constrictor muscle to the pterygomandibular raphe. So that's one of the key spread patterns that tells us that we're dealing with an anterior tonsillar pillar carcinoma. A rare type of tonsillar carcinoma is the posterior tonsillar pillar. And the posterior tonsillar pillar is formed by this muscle, which is the palatopharyngeus muscle. And again, isolated tumors involving these are very rare. And this was just an example of a clinical posterior tonsillar pillar carcinoma. So these are a couple of illustrations of 4 tonsillar carcinomas. The key information that we need to provide on this is, number one, whether or not the tumor is exophytic or whether there's deep spread. So on the bottom left T2 weighted MR, we can see a tonsillar carcinoma that's exophytic. And on the right-hand CT scan, what we see here is a tumor that's involving the left tonsil extending to the soft palate, and look deeply, notice how this is partially effacing the left parapharyngeal space. Instead of having a big black triangular fat, we can see that the fat here is effaced. Also, when we look anteriorly, we can see this tumor is growing along the superior constrictor muscle to the expected location of the pterygomandibular raphe. Now, this information cannot be seen clinically. In fact, one of the tumor boards that I attend routinely is I actually get to see every single patient whose imaging studies we review. So this just emphasizes the fact to me that although it's easy for us to see, and we think it's common knowledge, it's not. When our referring physicians look in, all they can really see is this exophytic component involving the tonsil, and they really are dependent on us for this deep spread. The second component of the oropharynx is the soft palate. So when I think of the soft palate, I always think of this Roman arch. So when I think of the palate, I think the columns of the arch are formed by the tonsillar pillars, And the soft palate connects the tonsillar pillar. So when I look at the soft palate, when we talk about the palatal arch, this is our palatal arch, and it's tethered superiorly to the skull base by two muscles, the Italian muscles we learned in medical school, the levator and the tensor veli palatine muscle. And I kind of think of those muscles as the top of the arch and the bricks or the stones that actually connect the top of the soft palate to the roof, if you will, of this Italian arch. So in a way, that's how I conceptualize the palatal arch. The middle here demonstrates a CT image demonstrating a squamous cell carcinoma involving the soft palate. And on the MR here, we can see a T1 weighted image post-contrast with fat saturation demonstrating a soft palate carcinoma. So these are examples of a soft palate carcinoma. On the left-hand side is a schematic illustration. On the top middle images, we can see a non-contrast T1 weighted images, and we can see the intermediate signal lesion here that's characteristic of a squamous cell carcinoma involving the soft palate. Now, one of the things interesting about a soft palate carcinoma is when you perform axial images, they tend to have this circumferential appearance. But when we look at this nice sagittal reconstruction, here's our normal anatomy of the soft palate. We can see on the sagittal images, we can see that these tumors are can get very big and bulky. So when we look at the axial plane, this is what gives us this circumferential appearance of a soft palate carcinoma. And just for grins here, we can see the retropharyngeal carotid arteries. So when we are looking for soft palate carcinomas, the issue is does it extend superiorly? So this is an example of a soft palate carcinoma. When we look superiorly into the nasopharynx, we can see the characteristic anatomy. Here's our torus tubarius, here's our opening of the eustachian tube, and here's the fossa Rosenmuller. When we see on the left-hand side, we can see the torus tubarius is a bit thickened. When we look at a T1 weighted image with fat suppression and contrast, we can see there's tumor growing along the torus tubarius, probably involving this little muscle right here, which is the salpingopharyngeus muscle. And when we do a non-contrast T1 weighted image, we can see that this tumor is extending all the way and replaces the normal high signal involving the petrous bone. Now, this superior extension was clinically occult, and it was only based on imaging where we were able to identify this. And when we did identify this, this patient was not treated with surgery, but was treated with non-surgical organ preservation therapy. The fourth area of the soft palate, of the oropharynx, I should say, is the posterior pharyngeal wall. So here's a schematic illustration of a posterior pharyngeal wall carcinoma. And as I mentioned before, this muscle that forms the posterior pharyngeal wall is the superior constrictor muscle. We talked about the anterior spread and the interdigitation with the buccinator muscle to form the pterygomandibular raphe. And here we can see the schematic illustration of the tumor. And on the sagittal images, this is a nice sagittal image illustration of a posterior pharyngeal wall carcinoma. Now, when we look at posterior pharyngeal wall carcinomas, again, they have a spread pattern just like anything else does. They can go laterally and they can also cross midline. And this is just an example of a posterior pharyngeal wall carcinoma that's extending laterally to involve the region of the left glossotonsillar sulcus. Now, if you look very closely here, there's a small little area of low attenuation here, which represents the retropharyngeal space just anterior to the prevertebral muscle. So one of the things that imaging can occasionally be helpful on is whether or not this tumor is fixed to the prevertebral fascia or potentially invades the muscle. Now, the classic way to determine whether or not there's posterior fixation is for to perform endoscopy and see if that muscle is loose. There have been various papers identifying that there is edema involved in the muscles that can be a very helpful sign, especially if there is edema involved in the muscles. Now, I have to admit, routinely in my practice, we haven't been doing MRs of the posterior pharyngeal wall to see if this fixed. This determination is typically performed clinically, but just realize that centers do advocate doing this. So far what we've done is that we've gone over the normal anatomy of the oropharynx, we've gone over the subsites of the oropharynx, and now we've gone over in great detail potential spread patterns of head and neck carcinoma. Now let's shift our attention for staging. So when we look at the 8th edition of the AJCC staging system, one of the new classifications is going to be what we used to call just oropharyngeal carcinoma. But as we'll get to in a couple of slides, there was a new disease that was created, which was HPV positive oropharyngeal carcinomas. So there is an HPV positive and an HPV negative. When we look at the HPV negative oropharyngeal carcinoma, this staging is very similar to the prior staging in the 7th edition for the oropharyngeal cancers. So essentially, it basically is just based on the size. So less than 2 centimeters, between 2 and 4 centimeters, or greater than 4 centimeters. And then in HPV negative, this is divided into a T4A and a T4B. And the differentiation between T4A is that this is still thought to be surgically resectable disease, I should say, and T4B is felt to be unresectable disease. So let me rephrase that. T4A is resectable and curable, and T4A is potentially resectable, probably incurable. But some surgeons will tell you they can resect any type of tumor. So one of the things that's new for the 8th edition for HPV negative oropharyngeal carcinomas is this involvement of the medial pterygoid muscle. So previously, when we had tumors involving the oropharynx that would extend into the parapharyngeal space and abut the medial pterygoid muscle, in the 7th edition, it would have been appropriate to call this T4A disease, again, in the 7th edition. But in the 8th edition, this is felt to be T2 disease. So one of the stage creep things, there was a lot of stage creep in the 7th edition, so we tried to be very precise as to determine what is true T4A and what's T2 disease. So if you see this type of abutment of the medial pterygoid muscle, this is T2 disease. If we see a oropharyngeal carcinoma extending laterally to involve the medial pterygoid muscle, in this case we can see it's completely infiltrated, this is both T4A disease in the 7th and 8th edition. So in the 8th edition, this is T4A disease. And the way that we determine whether or not it's T4B disease is whether or not the tumor extends laterally to involve the lateral pterygoid muscle and also potentially the masseter muscle as well too. And typically these patients do have trismus. So just a bottom line is that there's isolated involvement of the medial pterygoid muscle. This is T4A disease. But if there's involvement of the lateral pterygoid muscle, as is seen on the top right, this is T4B disease. So as I mentioned earlier, the 8th edition, we identified a new type of cancer, and that is the HPV positive oropharyngeal carcinomas. And I'm sure everyone on this webinar is familiar with this. And just to highlight a few of the uniqueness of this disease is that in 2013, oropharynx has overtaken cervical carcinoma as the most common HPV-related carcinoma. When we look at HPV positive versus HPV negative, the subsites tend to be in the tonsil and the tongue base for HPV positive disease. They tend to be basaloid carcinomas, arise in younger patients. Similar propensity in men, more common in men. The socioeconomic site tends to be higher. It is associated with a difference in sexual behavior, which is a risk factor compared to tobacco and alcohol, which is the primary risk factor for HPV negative disease. As I mentioned before, the incidence is increasing. But one of the nice things is that the survival is improved with HPV positive disease. Now, one thing I do want to point out is that in the United States, we know that there's a very high incidence of oropharyngeal carcinoma that's associated with HPV. Realize that the incidence of HPV with oropharyngeal carcinoma does vary worldwide. So in my travels to the Middle East and in India, the incidence of HPV positive disease in oropharynx cancer is actually lower in the Middle East and in India compared to the United States. And again, that's likely due to the risk factors that I mentioned before and difference in cultures. Now, the HPV status cannot be determined by site histology. It's determined by immunochemistry by overexpression of the tumor suppressor P16. And this is a cyclin-dependent kinase. And overexpression means that there's 75% moderate staining. So on the top left-hand corner, this is something that's HPV negative, and on the top right-hand corner, we can see all of that blue now stains with brown, and this would be considered HPV positive disease. So as we step through the rest of the talk, these will be little thumbnails just to reinforce whether we're talking about HPV negative disease or whether we're talking about HPV positive disease. So we talked about the HPV negative disease, very similar to the oropharynx in the 7th edition. But as I mentioned before, the HPV positive oropharyngeal carcinomas is associated with a better prognosis. So it is much more sensitive to successful treatment with non-surgical organ preservation therapy. And as a result, the staging reflects this. So still, staging from T1 to T3, again, is very similar. It's between size, it's less than 2, 2 to 4, greater than 4. But the big difference for HPV positive disease, for T4 disease, is that there's no A and B. Why? Because the success rates for treatment is much better. So therefore, the T4A and T4B were eliminated because a vast majority of these tumors can be treated with non-surgical organ preservation therapy. So if you will, it sort of takes out, someone argue, the need for surgery. So this is just an example of a patient with oropharynx cancers. Again, at the top left, HPV negative, the top right, HPV positive. And the good thing is that when you're just measuring by size, the staging hasn't changed. So here's a patient that has a 1.8 centimeter lesion. Whether it's negative or positive, it's still T1 disease. In this middle case, it was 3.5 centimeters. Again, T2, whether it's HPV negative or HPV positive, and on the right-hand side, a 4.5 centimeter lesion. Again, it doesn't matter whether it's negative or positive, it's still the same. So for those of you that don't do head and neck all the time, like many of us do, you can just say it's a little bit easier, if you will, just based on the size. But there have been some changes regarding once we get into the T4 diseases. So this is an example of a patient where there's tumor that was involved in the medial pterygoid muscle. In the 8th edition, this would be considered T4A, but if the patient's HPV positive, this is just T4 disease. So again, there's no A and B if the patient's HPV positive. This was an example of a large tumor involving the medial and the lateral pterygoid muscles. If the patient is HPV negative, this would be T4B disease. The patient's HPV positive, this is T4 disease. Why? Again, because a lot of these patients, these tumors can successfully respond to non-surgical organ preservation therapy. So we talked about the difference in staging for the primary site. Now let's talk about how this staging has affected end staging. So when we look at the lymph nodes, I've always said the lymph node, it's like a string of pearls. So when we look at the string of pearls, the clasp of the pearl necklace is the level 2. The anterior limb of that pearl necklace is level 3, then it transitions to level 4. The back of the pearl necklace is level 5, and where the anterior and posterior limbs connect is going to be the supraclavicular lymph nodes. And then anything that's below your chin, if you've ever scratched your chin or you have a dog or a cat and you scratch their chin, you've actually been palpating their level 1 lymph nodes. So when we look at the lymph node staging, again, there's a different lymph node staging classification, whether or not the tumor is HPV negative or whether it's HPV positive. And we'll go over that in great detail. The other concept that I want to mention here is the concept of extranodal extension, because extranodal extension comes into play on the subsequent slides when we talk about staging, lymph node staging for HPV negative disease. So extranodal extension is extension of metastatic carcinoma through the fibrous capsule of a lymph node. So this is just an example. On your right-hand side of a metastatic lymph node, the only thing I remember about pathology is blue is bad. So there's a lot of blue here, so it's probably bad. But then when we look to the little bit of the left here, we can see this blue is extending through the capsule of the lymph node, and this blue is extending outside of the lymph node, so this is extranodal extension. In early cases of extranodal extension, typically the only way to diagnose it is on pathology. But when we talk about clinical staging for HPV-negative oropharyngeal carcinomas, we have to mention the importance and the definition of extranodal extension. So first of all, when we look at the staging for HPV-negative oropharyngeal cancers for lymph node, this staging system, which is N0, N1, N2, N3, is essentially exactly the same as the 7th edition. So N0 means there's no regional lymph nodes. N1 means that there's a metastases in a single ipsilateral lymph node that's less than 3 centimeters, so it's small. N2A means that there's a metastases in a single lymph node between 3 and 6 centimeters. So the bottom line is that this N1 lymph node just gets bigger. So that's an N2A disease. N2B disease is when you start to having some friends in your same neighborhood, if you will, and that's metastases in multiple ipsilateral lymph nodes that are all less than 6 centimeters. And N2C disease, N2C means that they're metastases in the contralateral neck. So that means you've switched neighborhoods, you've gone over to the other side, you've gone across the street, if you will, and that is N2C disease when you have metastases in bilateral or the contralateral neck. So that's where the C comes from. And then N3 disease is a lymph node greater than 6 centimeters, so a big conglomerate lymph node. But the big change in the 8th edition is that all of these lymph node staging is based on the absence of extranodal extension. However, if you do have a metastases in a lymph node with clinical extranodal extension, and again, I want to emphasize clinical extranodal extension, this upstages the lesion to N3B disease. But it's very important now that we all understand the definition of extranodal extension, because I showed that pathologic slide before that early involvement. And we'll show slides of this later on, but we know that we can see extranodal extension on imaging. However, in the 7th edition, because of, if you will, some inconsistency on the criteria that was used, there was a bit of stage creep, and there was some concern that at times we were over staging lymph nodes based on maybe factors where there really wasn't extranodal extension. So in the 8th edition, extranodal extension is defined by involvement of the skin, adjacent musculature, neural structures, cranial nerve, brachial plexus, sympathetic chain, phrenic nerve, but this type of involvement has to be defined clinically. Now, that doesn't eliminate radiological imaging, because radiological evidence alone may be supportive, but is not sufficiently independent. So if we see what we think is extranodal extension, but clinically the patient does not have clinical signs of fixation, then really we cannot say that there's extranodal extension. So we cannot jump to N3B disease. So you have to have concordance of the clinical examination and the imaging findings. Now, what about the lymph node staging in HPV positive disease? As I mentioned earlier, the survival and the treatment response of HPV positive is much better than HPV negative, and this is reflected in the lymph node staging. So N0, just like the HPV negative, was no regional lymph node metastases. But once we get to N1, this is the big kicker. So N1 disease are ipsilateral lymph nodes that are less than 6 centimeters. Again, I want to emphasize 6 centimeters. Those are really, really big lymph nodes. N2 disease is contralateral or bilateral metastatic lymph nodes that are less than 6 centimeters. So again, a big change. We're still going to the opposite side. It's contralateral, but that upper threshold is 6 centimeters. And then if you have any lymph node metastases that's greater than 6 centimeters, that's going to be N3 disease. So let's step through these, and so we can give you some sense of the difference between the 7th edition, the 8th edition, and within the 8th edition, whether it's HPV negative or HPV positive. And again, just to reiterate, HPV negative on the right and HPV positive, on the left, and HPV positive on the right. So this is an example of a 4 centimeter ipsilateral metastatic lymph node. In the 7th edition, this would have been N2B disease. In the 8th edition, this would still be N2B disease, or it could be N3B disease if the patient had clinical fixation of that lymph node. So if there was clinical fixation, it would jump up to N3B disease. If there was no clinical fixation, then it would have the same staging as the 7th edition. But if the patient was HPV positive, remember the upper threshold was 6 centimeters, so this is N1 disease. Big, big change compared to prior staging systems. How about in this case? Now we have multiple ipsilateral lymph nodes that are metastatic. So in the 7th edition, this was N2B disease. In the 8th edition, if the patient's HPV negative, this is still N2B disease. But clinically, if there was fixation of these lymph nodes, this would be N3B disease. Now, here's the kicker. When I look at this, I see extracapsular penetration. I think, yeah, I think everyone would agree. But the challenge is that unless the patient clinically has fixed lymph nodes, this sole criteria cannot bump us up to N3B disease. There has to be concordance of the imaging findings with the clinical findings, and the clinical findings supersede the imaging findings. Now, what about if this patient was HPV positive? Well, again, all of a sudden, it's still N1 disease. Why? Because all of these lymph node metastases are on the ipsilateral side. So it doesn't matter whether it's one or multiple, it's all on the ipsilateral side. It's less than 6 centimeters. So this would be N1 disease. So it's a big, big pivot from what we understood before. But again, this is reflective of the better outcome of patients that are HPV positive. How about in this case? Now we have a patient with a left-sided glossotonsillar sulcus carcinoma. We can see that this patient now has bilateral metastatic lymph nodes. So how would we stage this? So in the 7th edition, this would be N2C disease. If the patient was HPV negative, this would still be N2C disease, or it could be N3B, again, just based on whether or not this was fixed. Now, again, on imaging, it certainly does look like there's extracapsular penetration, but only on clinical examination, that would have to supersede. So our imaging findings would have to be concordant with the clinical examination. If the patient was HPV positive, this would be N2 disease. So again, notice how there's no N2A, N2B, N2C. If there's involvement of the contralateral neck, this would be N2 disease. So again, differences here based on the new staging in the 8th edition. So in the last couple of slides, I think this will just give us hopefully a good visualization of the importance of HPV negative and positive oropharyngeal carcinomas. This was the 8th edition staging, and this was a patient that was HPV negative oropharynx cancer. So basically, green is supposed to be good, and the redder you get is bad. And the couple points that I want to point out to is that anytime that you have N2 disease, notice that you've got the pink and then you've got the red. So this all looks pretty bad. If you have T3 disease, it gets orange, then it gets pink, and then it gets red. If you have T4A disease, all the T4s are pink and red. So obviously, N2 disease is bad. That indicates stage 4A or 4B disease. T4A or T4B, again, 4A, 4B disease, and this is for HPV negative. But we do that combination, and now we say that the patient has an HPV positive oropharyngeal carcinoma, we can see the dramatic improvement in survival. So notice how N2 disease here is yellow, and T3 disease is yellow, and then the worst it really gets is in the orange that we saw before, which is stage 3 disease. Notice how there's no stage 4A or 4B disease. So the take-home message is that if you see something like this, as this arrow points, we can see a metastatic lymph node here that's involved in the muscle. If the patient's HPV negative and there's no extracapsular penetration, this is N1 disease. If it's HPV negative and there's clinically extracapsular penetration, this is N3B disease. If the patient is HPV positive with no extracapsular penetration, it's N1 disease. And even if there was extracapsular penetration with something that looks like this, this is still N1 disease. And that explains, if you will, the dramatic change, if you will, in the heat map between HPV negative and HPV positive tumors. So in summary, what I've tried to do over the last 20 minutes or so is categorize oropharyngeal carcinoma as HPV negative or HPV positive. We spent a lot of time going over the normal anatomy. We went through all the different subsites. We talked about the lymph nodes, and we specifically talked about the difference in staging. Now, what we did is we primarily talked about the imaging and the clinical staging. There is a pathologic staging too for HPV positive. We didn't get into that. But what I tried to do was emphasize what you will experience when you're in your day-to-day practice when you have these patients with oropharyngeal carcinomas on your queue, if you will. And we also emphasize the difference in staging. Point number 2 is remember that all oropharyngeal squamous cell carcinomas require immunohistochemistry for analysis and final clinical staging. And again, the reason I emphasize this is that if you're at a tertiary or quaternary care institution, then you're going to have all of this information presented to you so you can come up with the final staging. But not all the people that are going to be on this webinar are going to be able to work in a tertiary or quaternary care institution. You may not be going to your tumor boards. So therefore, you are not going to have the information regarding HPV positive or HP negative for these patients. And the only way that's going to do this is whether or not there's immunohistochemistry. So as a result, unless you have this information, it is important to measure the size of the lesion and also make lymph node measurements. And I understand that some people, you know, they may de-emphasize the measurements of lymph nodes. And I think if you're at an academic institution, you have all of that information, that's fine. You don't necessarily need to make the measurements. But if you're out in the community and you're trying to help your referring physicians not only identify the primary site, but to try to give them some initial staging, and also a little bit of assessment on the lymph nodes, and I think it is important to try to give some type of measurements for the primary site and the lymph nodes, and eventually that information will be factored into the final staging. So thank you very much for your attention. It's again a privilege to be here, and again I want to thank the Talking Heads group for allowing me to make this presentation. Have a wonderful day.
Thanks, guys. Those were some amazing talks. And now is the time when we're going to get a chance to answer all those questions that people have been typing in while we've been listening to the talks. The first thing that came up was questions on depth of invasion. Dr. Glastonbury, which radiologic modality is the one we should use to accurately measure depth of invasion?
Well, I think the question to ask that to is Dr. Stambuk, who did an outstanding lecture on oral cavity. And I'm happy to put mine in as well afterwards. But the best way to measure depth of invasion is with a microscope. It's a radiological measurement. But please, I'd love to hear Hilda's perspective.
Oh, I absolutely agree with what Christine said. As far as clinical staging goes, depth of invasion on clinical exam and imaging together is pretty close to pathologic staging. You're saying ultrasound? Is that what you were asking?
I think the question, I think I was sort of angling towards radiology can estimate and clinical can estimate, but we need to rely on pathology to get a precise measure of depth of invasion.
And that's absolutely true. And if you were going towards ultrasound, because people keep asking about that, in our institution, ultrasound is really not used so much for depth of invasion, but just to look for the deep margins for surgical resection. I think that's more helpful than the actual depth of invasion at the time of the OR. You've already decided in advance whether you're going to do an elective neck dissection or not.
Hey, Char, I just want to jump in here. I think one of the fundamental confusion that comes in is that we tend to confuse depth of invasion with tumor thickness. So when we look at the staging, we're actually looking at the depth of invasion based on the approximation of the basement membrane, histologically, which we can't see. And oftentimes when we do ultrasound, if we place the probe over the tumor, yes, we can see how far it burrows into the tongue, but in a way we're actually measuring the tumor thickness. So fundamentally, they are two different concepts.
All right. Hilda, another question came in about contrast in the oral cavity. Do you use biphasic contrast when you're imaging tumors of the oral cavity, and what delay do you prefer?
I'm not, honestly, I can't tell you what our delay is. I don't remember, to be honest, but we just use monophasic. Just the venous phase is actually completely adequate to see the primary and the nodes.
Yeah, I think the error that we see from other institutions from time to time is imaging too early, because people maintain the older protocols from back when CT took several seconds to go through the whole neck. Now that you can do it in less than a second, we need longer delays, and so we've come to have delays that are in the 80 to 90 second range rather than the 20-second delays that we used in the good old days. Another question that came up during your talk, Hilda, was the difference between the floor of mouth, the retromolar trigone, and the glossotonsillar sulcus. So I actually grabbed a screenshot from the middle of your talk, and I thought it was an image that would be a good one to show the to show the differences. Can people see my cursor on the screen?
Yes.
Okay, so Hilda, I wish I could quickly hand you the cursor, but I guess the thing I wanted to talk about was this range of stuff from here to here, and I guess I'll point while you talk.
You know, Char, I'm gonna have to give it to you, hon. I can't see your pointer.
Ah.
It's all yours.
All right, then. If other people can see my pointer, then the question was the difference with where we move from the tonsil to the glossotonsillar sulcus to the retromolar trigone, and these are continuous mucosal surfaces beginning in the lateral pharyngeal space on the tonsil, heading out into this glossotonsillar sulcus where the tongue abuts, and then all the way in. If we follow that along, we find our way to the retromolar trigone, which you discussed so thoroughly in your lecture. All right. Hopefully I'll find a way to get everyone seeing my, my cursor. And then another question that came in was, do we put TNM staging in our reports? And Suresh, I think you alluded to this towards the end when you were talking about it's great when you can go to an MDC, but you may not have all of the information you need to tumor stage in the absence of a multidisciplinary conference.
Yeah, you know, I think one of the great things about the 8th edition is that, you know, we really did add more molecular information and biological information into staging of tumors. But because we added more molecular information and biological information, that information is not typically seen in the front lines, because by the time the tumors get referred to a tertiary or coordinated care institution, they've already been through the community. And I know we, in our, from our perspective, want everyone to try to stage as much as we can, but it is a little bit challenging if we don't have that information. And once you have the information, then clearly you can do the final staging. So that's why I think, because the bulk of oral cavity, oropharynx is based on T1 to T3 is based on size. You know, I think we try to give as much information as we can to try to help facilitate the process and help our referring physicians in the front line make better treatment decisions.
At our institution, oh, I'm sorry, Hilda, I didn't mean to interrupt.
No, I just wanted to say in our institution, I don't stage anything. I just know the spread patterns and I report everything that will influence the staging, because there's things on clinical examination that I'm not familiar with. And if we have a pathologic staging or radiology staging and a clinical staging, it's very confusing for the patient. So I stay out of it and I just list everywhere it is. And you know, you have to know the staging system so you know what to report. But it's up to the clinician to pull it all together. And that's how we practice in our institution.
And Hilda works with a surgeon who was one of the lead surgeons for the AJCC staging for head and neck for the expert panel. And I imagine, but the rule of AJCC is that radiologists, I mean, it was discussed. I even tried to introduce an I staging, like you have a C staging, the CTNM and the PTNM for pathologic, an ITNM for imaging.
Mm-hmm.
Now, It's not, it's very clear in the AJCC that it adds confusion when you do that, and the staging should be done by one person managing the patient.
Okay. Well, we promised that we'd give away the answers to the Twitter cases that were sent out last week. So hopefully now everyone can see these two images and the laser pointer on top of them. Yeah? Are we getting yeses there from the audience? Okay, good. So this was case number one. We had a patient in whom an incidental finding was made, and when the radiologist went back to 2 years prior, they found the lesion 2 years previously. Maybe the difference in configuration here based on tilt of the imaging or something like that. And so the radiologist recommended that this be biopsied to make sure that, even though it was pretty stable for 2 years, make sure that it was truly something benign. I got a call from the ENT surgeon who said he couldn't find anything to biopsy. The mucosa was intact and wanted to know if this was a submucosal mass. And so I said, ask this patient how much she likes chewing gum. He literally called the patient, called me back and said, she says she always has a piece of gum in her mouth. This is a comestible intraoral foreign body. And this piece of gum is presumably not the same piece of gum that she was chewing on 2 years ago, but this lady always has a piece of gum in her mouth, and she's not going to spit it out for some CT scan. And this is where she likes to tuck it when she's getting scans, is right up into the gingival sulcus here next to her maxilla, always in the same place. This is chewing gum. The things that people put in their mouths and chew on tend to be much denser than soft tissue and are easily mistaken for bony masses, but they come in characteristic configurations and characteristic locations. So it's chewing gum, even 2 years later. Here's the other Twitter case. This one had the preamble, what if I told you this wasn't squamous cell carcinoma? Because when you see a mass arising from the tonsil, it's almost always going to be squamous cell carcinoma, just like all the examples we've been seeing for the last hour. But what if it isn't? Because this one isn't. What if it isn't squamous cell carcinoma? What is a mass arising from the tonsil likely to be? Well, if it's not infection and it is tumor, then the second most common tumor we're likely to encounter here is lymphoma. Squamous cell carcinoma and lymphoma, the two tumors that we commonly encounter arising from the tonsil. This one happens to be a lymphoma, although even though it's so uniform and pretty, I'd probably put squamous cell carcinoma first on my differential, just based on statistics. The unusual appearance of a common disease, more common than the appearance of an uncommon disease, some axiom like that. So those are the two Twitter cases.
Fun.
Are there any more questions on the Q&A, Char?
Let's see if we got any late questions. Yeah, here's nasopharyngeal and oropharyngeal cancers have different end stagings. How can we diagnose? What do we do? So this is sort of, a type of question. What do we do when a tumor extends across different mucosal regions? If it is an oropharyngeal and nasopharyngeal carcinoma, if it is an oral cavity and oropharyngeal carcinoma, how do we apply these disparate staging systems when we're not sure where it arose from? Want to grab that one, Suresh?
Yeah, I think it's a great question, and I saw who did it too. It's Mizium, who I figured would ask a great question. So this is where, for me, radiology becomes more of an art than a science, because I think we're all sort of taught the basics of localized lesions. So the way that I've always looked at this, because I have seen oropharyngeal carcinomas called unilateral nasopharyngeal cancers, and I have seen large lateralized nasopharyngeal carcinomas that have been called oropharyngeal cancer. So it certainly is challenging. So first of all, in 2008, there are ways to get around this a little bit more objectively. So if you do a biopsy and you send it, and I assume every place is doing a biopsy, you send it for molecular markers. If it comes back EBV positive, then it's nasopharyngeal carcinomas. If it comes back HPV, then it's probably going to be oropharyngeal carcinoma. So in a way, you can sort of take the guesswork out of it. If it comes back neither, then it's probably going to be HPV negative, P16 negative oropharyngeal carcinoma. So there is an objective way, which I think is one of the benefits of the 8th edition. The other thing that you can look for is, and this is a way that I learned when I trained in the last century, I take my finger and I put it where I think the center of the lesion is. And wherever that center of lesion is in 3 planes, then I think I found the subsite. So one thing that I have seen about oropharyngeal carcinomas that go to the nasopharynx, the involvement of the torus tubarius, the opening of the eustachian tube, and the fossa rosemular, in a way tends to be secondary. And sometimes the torus can be effaced as opposed to enlarged or completely replaced. So if I see the torus and I see a little bit of the torus that's sometimes displaced, or I think things are pushed over, then I think it may be oropharynx. If I see everything completely replaced and I see deep extension through the pharyngobasilar fascia extending laterally, and I think that's where the majority of the deep extension is, and I think it's nasopharyngeal carcinoma. So that gets more in the art of the science, but now from the science, the first thing I would say is do your molecular, your immunologic testing, your EBV testing, and your HPV testing, and see what it comes back.
Yeah, great answer. So the last question on here is a request for me to go over those anatomic landmarks again, this time with my cursor working. So let's try it again with the cursor working. Hopefully you can see the moving version of the cursor here. Here's the tonsillar pillar. If we follow that mucosa.
Char,
Yeah.
honey. I
Can't see anything.
You look
Can you share your screen?
And to share the screen, let's try this.
Hold
Are we
on.
there? Did that work?
Yay.
So we're looking at your PowerPoint of your case, I think.
Yeah.
And not the actual screen of it?
I'm looking at
No, I see your arrow now.
cases.
Your arrow's moving.
How about?
Yes.
This is good?
Yep.
All right, we're gonna do it like this. So here's the tonsil itself. If we follow that mucosa back, we're going to find ourselves into the glossotonsillar sulcus, which is where these mucosal surfaces oppose. If we continue along that further, then we find our way into the retromolar trigone, which is what Dr. Stambuk was talking about so eloquently in her lecture. Hopefully this time viewing it cleanly. All right, and that was the stack of questions. Great questions in there. People paying attention.
Well, thank you, Char, and thank you, everybody. Suresh and Hilda, just outstanding lectures as usual. Amazing. Really, really appreciate you two sharing all your expertise. I know you do a lot of this, and thank you for taking care of your patients, but thanks for sharing all the things that you've learned with everybody here, nationally and internationally. Char, do you want to sign us out?
Well, thanks everyone for coming. We look forward to seeing everyone at the ASHNR 20 virtually in this exact same location that you're in right now, I assume. It's more fantastic lectures like the ones you heard today, so everybody sign up and come and see us at the ASHNR.
Take care. Stay safe.
Bye-bye.